Hi there. I'm Dr. Jill Zwicker, and it's my honor to be able to introduce to you our trainee lightning talks for today. As a former trainee myself, I'm very honored to be able to give back and introduce our trainees. So we have 4 trainee talks. I'll introduce all of our speakers first, and then we'll have each of their lightning talks, followed by a question and answer period. We have Dr. Samantha Machinsky, who is a registered nurse. She's completing a postdoctoral fellowship at McMaster University under the supervision of Dr. Michelle Phoenix. We have Christopher de Groot, a research coordinator at BC Children's Hospital, working with Dr. Jean-Paul Collet. Erin Klein is an occupational therapist completing a Master of Science in Rehabilitation Sciences at the University of British Columbia as one of my trainees. And we have Preeti Kaur, a PhD candidate at the University of Calgary, working under the supervision of Dr. Catherine Labelle. So we'll proceed now with our first talk, and please keep track of your questions on Slido.
Hi, my name is Sam, and it's my pleasure to present to you today on behalf of the Learning Together project team, which is part of my postdoctoral work. Engaging patients beyond traditional participant roles has significant impact on the research process and outcomes, including enhanced relevance, quality, impact, and utility of research findings. But to see the full benefit of the patient perspective, patients need to be involved in all aspects of the research process, from design to dissemination. The problem is that researchers and patient partners may lack the knowledge and skills to engage in authentic and meaningful partnerships, which can lead to tokenism and inauthenticity. Research teams face increasingly complex relational challenges, and few training opportunities exist that support collaboration in an environment where stakeholders learn together. To fill this gap, we identified 2 specific strategies. 1, training that includes patients and researchers together, and 2, building an environment that supports trust and co-learning. Co-learning allows stakeholders, including researchers, research staff, trainees, youth, and parents, to reflect on challenges and look at issues from different perspectives so that the learning is relevant, while simulation allows learners to experience each other's challenges firsthand in a safe and controlled environment to co-create solutions in real time. A simulation-based co-learning approach was used to create 4 video training simulations for diverse stakeholders, while a case study approach was used to examine how stakeholders construct their co-build experience. In Phase 1, diverse stakeholders shared stories to discuss their challenges with engagement. In Phase 2, actors joined the stakeholders to refine the simulations, and in Phase 3, the actors recorded the simulations with our AV team. Participants involved in the research were audio and video recorded in Phase 1, and notes were taken during the story sharing exercise. We then conducted follow-up interviews with researchers, trainees, and parents. Initial themes were developed, and thematic analysis is currently underway. Through the simulation co-build, 4 unique simulation videos were created. The topics included finding a research partner, setting research objectives, navigating knowledge translation, and reviewing results with youth partners. 4 themes were identified from the observations, videos, and initial review of the interviews. We found that barriers limit participation from diverse groups of youth and parents. Youth and parents described feeling that they were often invited onto projects to tick a box. There was also a tension between the limited scope that people are asked to contribute while being asked to speak for a wider population. Lastly, we found that parents and researchers can bring very different motivations and expectations to the project. The next phase of this research will include implementing and evaluating the 4 video simulations, which has been granted funding from ChildBright to conduct this work later this year. On behalf of the research team, thank you so much for listening.
Hi, my name is Chris de Groot. I'm the research coordinator on the Collet research team studying the impacts of the COVID-19 pandemic on physical activity of children. The COVID-19 pandemic has presented many challenges to staying active for children with neurodevelopmental and intellectual disabilities and their families. Learning developmental opportunities, socialization, and general well-being of families is being put in jeopardy. Our study aims to achieve 4 key goals: to describe the effects of the restriction of group activity, identifying barriers to physical activity, the impact of decreased physical activity, and the identification of supports that parents need. We conducted a survey containing both open-ended and multiple choice questions. 245 surveys were sent out, and of those, 35 surveys were completed. Following the prompts listed below, parents clearly indicate the importance of physical activity for their children. 75% of parents agree that they consider physical activity important for their child's mental wellness, social development, and psychosocial functioning. 63% of parents had serious concerns about the lack of physical activity for their child. Clearly, physical activity is perceived as very important to parents. Likewise, parents realize what's at risk during the pandemic. 90% saw a decrease in their children's social interactions with peers outside of the home. 75% noted increases in screen time, and more than half reported decreases in social interaction. Just under 50% of parents reported an increase in their child's anxiety. Parents are affected as well. 59% of parents reported families were struggling due to the effects of social isolation, and half of parents reported negative impacts due to depression and anxiety. Unfortunately, parents indicated that they were not receiving adequate support. They told us they would like to see more opportunities for virtual practice of various activities, organization of small group activities within COVID-19 guidelines, and other ways to virtually engage with other children and families. Based on these responses, our team has the confidence to put forward strong strategies to give program tools and interventions for parents and children, to find solutions to foster ongoing child development, and to guide our team's development of a virtual system to help parents keep their child active in a structured way during these times. Thank you for your time.
My name is Erin. I'm an occupational therapist and a master's candidate. The project I will be presenting on today is part of my master's thesis. Developmental coordination disorder is a common neurodevelopmental disorder that is under-recognized and underdiagnosed. DCD is characterized by significant delays in motor coordination, impacting all areas of daily functioning, with challenges that persist into adolescence and adulthood. In British Columbia, there is no standard of care for families to access diagnosis and treatment. To change this narrative, we need to understand parent perspectives on their needs and priorities when attempting to access a diagnosis and therapy. Therefore, the objectives of this study were threefold. Firstly, to understand how parents navigated the healthcare and school systems, which rehabilitative services and supports families determine as beneficial, and finally, identifying potential barriers and facilitators for diagnosis and treatment. We utilize a cross-sectional study design using the Impact for DCD questionnaire, which contains both open and close-ended questions. The questions were distributed through an online link using a multimodal sampling strategy. A mixed methods analysis was used. Frequency counts and percentages were used to determine data trends and patterns. Medians and interquartile ranges were used for continuous variables. Associations between categorical variables were determined through chi-square analysis. And finally, a content analysis was used to understand emerging themes from exploratory questions. Families identified gaps in healthcare and schools. Even though parents identified motor challenges around age 3, the median age of diagnosis is 8. Inconsistent information from healthcare professionals, educators, and their own limited personal awareness contributed to longer wait times. Inconsistent access to school-based clinical evaluations led families to seek out private assessments, contributing to inequitable access. Families reported limited school-based therapy services with long wait lists and not meeting eligibility criteria. This led parents to seek therapy in the community, with more than 3/4 of families paying privately for these services. Families reported low satisfaction for supports and services that address emotional and social function. At school, parents reported lack of supports and services and inconsistent educator knowledge about DCD. This led to social and emotional challenges for their children, such as poor self-esteem and anxiety. Parent priorities included timely and funded diagnostic services for early identification. Their children need therapy, which requires funded school and community-based clinical supports and services that address motor, social, and emotional well-being. Their children need support at school through access to services and resources, in addition to curriculum supports. Increased capacity is required for educators on the impact of DCD in school function. Next steps in this study include compiling a policy brief to effect change for provincial standards of care, outlining parent-identified needs for services and supports. We will also be distributing the Impact for DCD questionnaire Canada-wide for awareness, advocacy, and a comparative analysis to inform national standards of care.
My name is Preeti, and I'm excited to share my project with you today. Prenatal alcohol exposure, or PAE, can result in a diagnosis of fetal alcohol spectrum disorder, or FASD, which has a prevalence estimate of 4% and a significant cost in Canada. Individuals with FASD have varying degree of impairment in 10 neurodevelopmental domains. Our lab uses neuroimaging to investigate neuroanatomy in particular, as small changes to brain structure can underlie substantial impairments in the other domains. Specifically, we use diffusion tensor imaging, or DTI, a technique that tells us about overall white matter microstructure. We can extract specific DTI measures such as fractional anisotropy, or FA, where higher FA tends to relate to greater white matter connectivity. Previous DTI research in the PAE FASD population has focused on the older participants and has shown less white matter connectivity, or lower FA, relative to unexposed controls. We currently know very little about the neurological profiles of young preschool children with PAE or FASD, even though early childhood is a critical time for development, identification, and intervention. Therefore, we aim to investigate differences in white matter microstructure in young children with and without PAE. For our methods, we currently have 54 kids with PAE and 54 age and sex match controls. Between the ages of 2 and 7, kids were scanned on our rocket ship MRI at the Alberta Children's Hospital. We processed our DTI images and calculated FA for the whole brain and individual white matter tracts, each with a unique role. And lastly, we did a multivariate test of covariance to compare groups controlling for age and sex. So here are our results. On the y-axis, we have our FA values. On the x-axis, our white matter tracts. In purple, PAE kids. In blue, controls. And what we see overall is higher FA in kids with PAE and lower FA in controls. This is significant for the whole brain, the genu, and the body of the corpus callosum, and the pyramidal tracts. It was only in the fornix where we saw the opposite. In summary, we are seeing greater white matter connectivity in young children with PAE at the whole brain level and in tracts associated with cognition, motor, and social emotional processing. Interestingly, our findings are the opposite of previous research in older participants with PAE and FASD. And it's possible that protective or compensatory neural mechanisms might be taking place in early childhood. I'd like to thank you for listening, and please come check out my poster for more information.
Wonderful. Thank you so much, Samantha, Christopher, Aaron, and Preeti for your presentations. So for the audience, this is just a snapshot of their work. So the floor is now open for questions. And just a reminder, if this was just to whet your appetite, but to please go to the poster session today at 4:45 Eastern Standard Time to find out more from these trainees as well as other trainees in the network and the important work that they're doing. So while we're waiting for other questions to come in, the first question we have is for Christopher. Can you tell us some examples of what you're going to do in the virtual platform to support families during this time of COVID?
Yeah, so we were quite fortunate with the timing in that our plan was always to build a website around this time. So as part of our implementation, we want to have an online presence, but then this is just more natural with the COVID-19 pandemic happening. So we've been able to add in all kinds of virtual supports that we are currently planning, developing, and building with a website design company. So those types of specialized supports include things like online training modules that will help coaches and parents with specific training to understand things like physical literacy, how to conduct assessments, specialized things to how to do these kind of activities at home, what constitutes proper form, and just all kinds of different principles of physical activity, as well as creating a space that parents can kind of have that ability to have that social networking kind of thing happening and being able to communicate with coaches and get feedback from coaches, but also communicate with other parents and just overall get a great amount of resources that will be especially important during these times.
Great, thank you. And then Samantha, I wonder if you could just describe some of the future steps of your work.
Yeah, so we are using the simulation training videos to build as the basis of an implementation and evaluation project. We're hoping that these simulation training videos will be used by not only clients and families, but also by researchers, trainees, research staff, to be able to have the tools to support them and authentically and meaningfully engage as partners in research projects.
That's great, thank you. And then let's see, Erin, can you tell me what are some of the typical pathways that parents are using to acquire a diagnosis of DCD at this time?
So, you know, what we have, what's available now is there's a DCD clinic through Sunny Hill, and you know, that tends to be kind of the typical pathway. So, you know, when there's a concern, when families identify a concern, their first step is obviously to go to their family doctor to start to initiate that referral process. And then they'll either refer to a pediatrician or to the DCD clinic, but more often the pediatrician will refer to the DCD clinic, and that's where families can access an assessment with an occupational therapist and a developmental pediatrician. Now, obviously, the concern is that you know, there's significant wait lists, and you know, that kind of led to the impetus in terms of trying to find another diagnostic pathway, because best practice is really having a streamlined pathway for families. So they, you know, we're through some of these toolkits for pediatricians is trying to build capacity for pediatricians to diagnose DCD rather than waiting for a developmental pediatrician and an occupational therapist, particularly for a developmental pediatrician. You know, when you have a case that's more complex, that might be more when you need that pathway. But even though there's these, you know, pretty streamlined pathways in BC, families are still identifying these long wait lists. So, you know, really having a funded system, you know, and if we're going to build capacity with pediatricians so they can diagnose, the issue is that, you know, where they're going to get the occupational therapy assessment, you know, and that's where when families are identifying these lack of clinical evaluations through school, they don't have access or it's inconsistent access, you know, how does that build capacity with the pediatrician? So there are pathways in BC, but the issue is that there's just not, the funding is not there, and the wait list, even though we're trying to delineate these very two clear pathways, you know, this is where the barriers start to come into play in terms of, you know, so if the pediatrician has capacity to diagnose, where do they get this OT assessment from? So then it takes them back to the DCD clinic, either to wait for this OT assessment or to pay privately. So this is where the barrier is. And this is just in BC. And the unfortunate thing is, again, there's no standard of care. There's no national standards of care. So what we face in BC might be completely different to what the challenges are facing in Alberta. So that's where those next steps are going to come into play in terms of figuring out what's happening Canada-wide, and, you know, going back to the parents to really trying to find, you know, funded multidisciplinary assessments so parents have an easy access for a diagnosis.
Yeah, definitely we need some more advocacy work there. And then Preeti, I wonder if you could describe in a bit more detail why you chose those brain regions that you did to examine in your sample.
Yes, absolutely. So we had chosen about 10 major white matter tracts to examine. And these tracts have essentially been extensively researched in previous literature looking at typically developing youth. And therefore studying them in a sample that has prenatal alcohol exposure it allowed us to have this baseline foundation of information to compare with. These tracts are also associated with a number of major roles like cognition, social emotional processing, and motor skills, which we know youth with FASD struggle with in terms of those domains.
Okay, great, thank you. And then we've had a question for Christopher come in again. Are you looking at whole family activities, or is the focus on child exercise and recreation?
I'd say the main focus is on child recreation, but we definitely have a strong focus on including the family, particularly, doing things like giving login access to grandparents if they're involved in the care. Obviously, with COVID at this point, that's probably less likely, but involving their siblings if possible, and then also, again, future-proofing it, like hopefully when the pandemic ends, being able to include it with, other children such as their friends or siblings or just people from their school. So there is a focus on kind of group style as well, as that's very important. But currently and more specifically, it's definitely focused on a specific child.
Okay, great. Thanks for the clarification. And then Samantha, we have a question that's come in for you. How do you see this simulation training videos impacting clients and families?
Yeah, that's a great question. So we're hoping that these simulation training videos are going to be able to make the learning relevant and be context driven so that parents and families have those supports and those resources and tools that they can use when engaging in research projects as patient partners. So we're hoping that not only it'll benefit clients and families, but also researchers and trainees and research staff as well.
Great, thank you. And we probably have time for one more question here. Preeti, will you be able to repeat the scans on the children to understand what might be happening developmentally?
Yes, absolutely. So our sample of children, about 54 kids, they return for scans every 6 months. And basically we are hoping to continue following them into adolescence as long as we can go. At the age of 7, they start returning either every year or every 2 years. Some of our families are not from Alberta, so it's quite a bit of travel to get them to Calgary to be able to scan them. So we really do hope to see how these tracts and brain regions are essentially developing with age and what trajectories we are going to see.
Okay, great. Thank you very much. And unfortunately, we can't take any more questions at this time, but for those of you that continue to have questions, please visit the poster session beginning at 4:45 Eastern Standard Time. I would just like to thank the trainees for their presentations, and I'll turn it back now to our MC, Dr. Brian Goldman. Thank you so much.
Thank you, Dr. Jill Zwicker, for skillfully handling the lightning round. I want to thank Samantha, Christopher, Aaron, and Preeti for sharing with us your fantastic insights on research and delivery. And you've given us lots to think about. We're going to take a short break now. Why not head over to GatherTown for our exhibition and networking session? It's moderated by KBHN Research and Training Manager Doug Swanson. Click on the link at the bottom of this live stream to create your avatar and start networking with your colleagues and peers. And we will be back here at 2:50 p.m. That's Eastern Time. That is 11:50 a.m. Pacific Time, as we focus on service delivery and research during COVID-19 and how we redefine our new normal. Until then, enjoy your lunch, and I'll see you virtually in GatherTown.